Hello, everybody, and welcome to our fourth session in our sixth session, Connecting, Coaching and Changing Lives pilot program for AOD, new and burgeoning nurse practitioners and those that have nearly started or are actually trying to build some knowledge in the area. Welcome aboard, and it's great to see you all again as winter hits us and from the various states that you're actually coming to us from. So welcome, as I said, and Colleen, if you don't mind moving to the next slide. Thank you. Before we begin, let's do our acknowledgement of country. And as we gather for this meeting, physically dispersed and virtually constructed, let us take a moment to reflect the meaning of place, and doing so recognise the various traditional lands on which we do our business today. We acknowledge the elders past, present, and emerging of all the lands that we work and live on, and their ancestral spirits, and gratitude and respect. And for me, that's I'm coming from the lands of the Bundjalung people up in northern New South Wales. So thank you very much. And Colleen, if you don't mind moving to the next slide. Look, we just still need to be mindful that we probably wouldn't be doing this if it wasn't for AbbVie. We obviously approached them with this idea because we felt that it was desperately needed, that as those that were emerging or had recently established drug and alcohol nurse practitioners needed something. And for a company to come on board and do that, I have to say, hats off to them, because not a lot of companies will do that for nurse practitioners. So I think we need to be really appreciative that there's groups out there that do actually acknowledge our skill base and what we can bring to the table and in treatment of hepatitis. Thanks, Colin. Okay, moving on to business. As you can see, this month we have our topic is opioids. That will be presented by Michelle Pitcaithly, who's located down in Victoria. After that, we will have a Q&A session as per usual. Can I ask for all, though, if you have a question, please place it in the chat. I would ask the mentors that are currently on if they could assist with answering some of those questions. If some of them aren't answered, we hope to and endeavour to answer those following Michelle's presentation tonight. Need to basically highlight, though, when we do go to our break at 6:45, could I ask that those that are not attached to the CCC program say their farewells, because it's only those that are that will be allowed back in to our peer support section following, which will be covering an opioid case study. So without further ado, let me introduce Michelle. Michelle Pitcaithly began nursing in 1979. That was general and mental health in the UK before coming to work in mental health in Australia. Michelle has worked in the area of mental health and forensic mental health inpatient units, rehabilitation units, and then moved on to mobile support and treatment teams. She's gone on to work in acute psychiatric triage, then moved into management of rehabilitation services before moving into custodial management, then back to the emergency department as a senior AOD clinician in care coordination. She has moved into AOD specific services, working in intake, care coordination, non-residential withdrawal, and then pharmacotherapy. Michelle obtained her master's in as nurse practitioner in 2015 and remained in the AOD service for 18 months before moving into medication support and recovery services, which is a statewide medication reduction service with a multidisciplinary team, which she remains in currently. Michelle is passionate about nursing, nurse practitioners development, mental health, and AOD, and the hepatology scene. Michelle, I'm going to hand over to you, and all the best. Thank you.
Thanks, Darren. So what I'm going to present tonight is all to do with opioids. And there's a fair bit of information here, and probably I'll be going pretty fast to get it all there, but also you will get the slides. So some of the background information: heroin was invented by the Bayer Company in 1898 and marketed as a non-addictive analgesic and suitable for children, which is just gobsmacking. In New York City, the street name was, as you can see, in the 70s, just to discredit it. And then we moved on, and I've called it opioid agonist therapy here, but we all know that it's ORT, OSTP in various organisations, various outlets. But currently in the state of Victoria, we've been told to use opioid agonist therapy. So I've sort of put it under that banner. Have several reasons for its use in opioid use disorder: having a long duration of action, cross tolerance with other opioids, an effective oral, and obviously now the subcut administration. And there's good research standing for economic and forensic benefits. Next slide. Interesting factors. Estimated cost of opioid use. Now, I tried to get some up-to-date data, but this is all I could get because of COVID, obviously interrupting with some of the stats. And there was 15.76 billion and 2,203 deaths. And that came out of the NDRC, which is the National Drug and Alcohol Research Council, in May 2020. So even although it was reported in 2020, it was data like 4 years previous. Heroin use in 2019 from the NDSHS, which is the National Drug Strategy Household Survey, was reported as less than 0.1% of the population. I'm not going to go through everything that I've documented there. I think as nurse practitioners, you're well able to read most of the stuff that's on the slide. Codeine use dropped from 3% to 1.5% between 2016 and 2019. And I think that was really people starting to get really used to the idea that it was getting scheduled in 2018, and people starting to get a bit panicky. What am I going to do about my codeine? And as we all know, codeine converts to an opioid when it's introduced into the body. And that's where part of my service came into fruition, because around that time, that's when the department in Victoria looked at funding this. And there is an estimated number of people misusing pharmaceuticals, any pharmaceuticals, in the last 12 months is around 4.2% Australia-wide. Prescriptions for opioids estimated at nearly 1,000 milligrams per day per 1,000 population, and 1,362 scripts written per day, which is just absolutely mind-boggling that there's that many opioid scripts written in one day across Australia. There's higher opioid scripts for inner and outer regions, and 1 in 10 Australians have said that they've used at least one opioid for illicit purposes. And then the National Opioid Pharmacotherapy Statistics annual data said that approximately 50,000 people on opioid agonist therapy, or ORT, opioid replacement therapy. And this was excluding Queensland only because the data was during COVID times and the Queensland government were late in submitting their data. So that's the reason for that. Medium age is about 44 years and more males than females. Next slide. What are opioids? So opioid drugs are substances that have similar action to morphine in the brain. And that's according a quote direct from the Australian Drug Foundation, quote unquote, in 2021. And they include all of the ones that's listed there. So the opioids, codeine and heroin, all classified under opiates. Semi-synthetic opioids, Oxynorm, Oxycontin, Endone, Tarjan, they're all under semi-synthetic opioids. Fully synthetic opioids is fentanyl. And then you've got opioids under narcotics. And as I said, since February 2018, access to all opioid pain medicines has required a script in Australia. What do they look like? This is just some pictures that I found on the net, just to sort of highlight, you know, come in various shapes, forms, drug paraphernalia for heroin use. Some come in capsules, some come in tablets, depend whether they're made in a lab or in somebody's backyard in Thailand. And I mean, we all know that a lot of our clients get them off the net, and yeah, they look professionally made, but yeah, sometimes they're not. Next slide. And this is just some pictures of poppies and heroin and just all different ground down. So, you know, you might get white, you might get sort of a beigey color, and you might even get right through the black color. And it depends on where it's grown in the region or what country it comes from. Next slide. Opioids with other drugs we call polypharmacy, and the effects of mixing opioids with other drugs include alcohol, prescription medications, and all over-the-counter medications. And they're often unpredictable and can be lethal. Even some multivitamins are always asked if they're taking any multivitamins, the clients. And some of them examples are the consumption of alcohol while taking a cocktail of opioids and aspirin and Brufen, and they just keep on popping the pills because they're looking for the magic pill. And this leads to obviously stomach irritation, leading to some discomfort, and then they start taking more, and it can even lead to esophageal varices with the mixture of alcohol and other medications that just lose the lining of the stomach without the client realizing it. Taking codeine with other drugs such as benzodiazepines, certain antidepressants and certain antihistamines can increase the depressive effects and induce respiratory depression. And a lot of people don't realize this. They say, oh, but you know, mixing them, it doesn't really matter. But you say, yeah, it does, because the respiratory depression, if it's too much, you can actually just die in your sleep. And that's been highlighted a few times in some of the coroner's reports. The effects of any drug vary from person to person, dose, quality, strength, where it's manufactured. Covered a little bit about analgesics here, both the S4s and the S8 medications. Obviously, analgesias known as painkillers, and they relieve pain. and you get a lot of clients that say, oh, I need this and I need that, and do a bit of a cocktail. And now we're starting to see a lot in combination, because like we've got Panadol and Brufen mixed. And the other thing is the names that some of the companies give to these newly mixed medications, and people don't even realize what they're taking. And especially like cod, cold and flu. Oh, but I need to take paracetamol once. Signs of dependence. Next, Colleen. Opioid dependency is when a person is physiologically and psychologically addicted to opioids, and that's under the DSM criteria as well. The locus, and I always get the pronunciation of this, cereus, LC in the brain, is also affected by opioids. And the LC causes release of noradrenaline, stimulates wakefulness, respiration, blood pressure, and when affected by opioids, suppresses the release of noradrenaline, which induces drowsiness, respiratory depression, and hypertension. So a repeated exposure leads to upregulation of the noradrenaline release. And when these opioids are removed, I always say to clients that your neuroreceptors are sort of looking for these drugs, and then you get a relative overbalance of noradrenaline, and then that's when the withdrawal symptoms start happening. Some of the effects experienced after taking opioids, they're all listed there. The most common ones is the intense pleasure, and then they've got the dry mouth. I've sort of amalgamated the two there. Reduced appetite, a lot of people like that. They obviously don't like the nausea and vomiting, although if they've got a body image or a weight issue, maybe they do. Lowered cough reflex. Obviously, a lot of people after the codeine regulation started going for the cough medicines that had codeine in them, or synthetic codeine. And that's where I found a lot of my clients were coming from, that were addicted, and it was like a full-time job before they went to their full-time job to go around all the pharmacies and get a bottle of cough syrup every day. And you've got the drowsiness and the constricted pupils. So as I say, the list is there, and that's the effects experienced after taking the opioids. Next. So what do we do for assessment and management? So when I'm doing a clinic, on the first appointment, I try as much to conduct it in this way. So trying doing a full assessment, including physical, mental health, and psychosocial, taking into the thoughts of the pharmacokinetics and the pharmacodynamics, checking the safe scripts. And what I've noticed is that more drugs are being added as of July this year. Opioid withdrawal management, I talk about that. I say to them, you know, like, have you ever withdrawn from opioids? When do the feelings start coming on? Prescription opioids, ask about what they're taking now, what they've taken in the past. including full blood examination. So if you've got them there in the clinic, I try and get as much done as possible. ECGs, send them for an ECG in alignment with their recent cardiac issues. When we've known for a number of years about the methadone cardiac issues, but now the Suboxones long-term starting to become more apparent. And try and do the STDs, so the sexually transmitted diseases, and the blood-borne virus, especially hepatitis C screening, all included there. So just for the hepatitis C, I've put that in there so that you know what you're supposed to be doing. Because when I started as a new nurse practitioner, I had a little sticker and I used to go, oh my God, what sort of a, what kind of blood tests am I ordering? And am I going to look like a complete idiot and don't really know what I'm talking about? Next slide. And a lot of the clients don't even realize that there's the new medications for hepatitis C. They still think on the interferon days. So the management of withdrawal. So this is just a graph that was kindly donated from Jason about opioid withdrawal. So it just shows you withdrawal from heroin and withdrawal from methadone. So, I mean, heroin's a lot quicker, and the methadone duration 10 to 20 days and sometimes more. So you've got to take that into consideration, especially if you're swapping them from methadone over to Suboxone. Next one. So a person coming down who is in withdrawal may feel irritable and depressed as the drug starts leaving their body. Withdrawal symptoms can start within 6 to 24 hours, and that's with any sort of opioids. That's just given a sort of a ballpark figure. So it's sometimes people withdraw a lot quicker because they're metabolizing a lot quicker as well. And you do get withdrawal symptoms usually peak within 1 to 3 days. I usually start looking for the peak around that. Sorry, the chat's just covering over my wording. And as I say, it's all dependent on the half-life of the opioids. So we're all individuals. We treat people as individuals, and their medication withdrawals are all an individual plan. And that's what I do. I work with the clients and do an individual plan rather than doing a stock standard. But I've also got a sort of a regime in my head what I'm going to do. Medication for withdrawal. Every service does it a bit different, and we obviously have to work within our services constraints. And this is a snapshot of on average what inpatient units medication regime is. So diazepam roughly starting around the 40 up to 40 milligrams daily, and this is for the average patient. But I have saw people that we've had to go back into the inpatient unit and bump up their Valium because they're sitting at 120 milligrams. So there's no right or wrong, and you have to just be observing the clients about the use of the the diazepam, metoclopramide for the vomiting and nausea, but also metoclopramide can actually give people irritability and that jittery. So you're obviously watching for that as well, and you might have to give them a different antiemetic. Magnesium, 2 to 4 tablets a day. Start them. Some services do 2, some do 4, some do more. Got to be mindful of the side effects, having been inducing diarrhea, and that's really off-putting for some clients. Multivitamins, just to give them a bit of a boost. Non-steroidal analgesics like paracetamol and ibuprofen. So obviously watching your maximum daily doses. Panadol 4 grams a day, ibuprofen 1,200 milligrams a day on the PRN sheet. And obviously non-residential withdrawal, so NRWs, so people in the community, you err on the side of caution, but you normally, all the rest is the same as far as the medications are concerned, except for the Valium, and you would be tending to use between 30 and 40 milligrams would be my maximum in the community. If they needed any more than that, I would say, no, you're too risky, too high a risk. I'd rather you be in an inpatient. Next one, medication overview. So we're moving on to opioid agonist therapy. So in some states, some services, the custodial services, I think still in Victoria, call it OSTP, so opioid substitution therapy. ORT is used, opioid replacement therapy. OTP, opioid treatment program in New South Wales, I was told the other day. But when it comes down to it, there's 3 opioid agonist therapies, which include buprenorphine, methadone, and naltrexone. And use of the drug company resources to give clients to take away. So these appointments that you have with the clients, they're really, really busy and you've got a lot to do. And some people are still sitting on the fence and say, I really want to do the right thing by myself, but I'm a bit unsure. So you use what the drug companies are giving you. There's a fantastic resource at the moment that Indivior have just launched. And it opens up like a little mini iPad, and it takes people through the long-acting injectables. So, and it's got all the little leaflets inside that. It comes in a little box and shuts down. And I find that really useful, using it in the first session that you're trying to persuade somebody to go on buprenorphine if they're not already convinced by the time they come through the door. Methadone, naltrexone, some people come in and they've already made up their mind. Next one, pharmacotherapy commencement. We've been using SafeScript in Victoria for a while now. I can't even remember when, April 2000 and whatever, I can't remember. But I know it's been a while, and I find it absolutely fantastic. You can get a lot of information off it. You can find out if they've been to somebody else for pharmacotherapy. You can find out what the dosing pharmacy is. You can find out if they've been doctor shopping, and most of the electronic prescribing platforms now incorporate it into your prescribing. So like at work, I use Medical Director, and as soon as I start typing in and looking at things, it comes up where a red alert or an amber alert or a green alert. And that just means that they haven't had another prescriber for these drugs of dependence in the last 6 months. We apply for a permit to the department. I don't know what happens in other states. I have been told that it's similar. You just apply. You take an ID picture and you put it, well, we have to take a picture for ID purposes for the pharmacy, put it on letterhead, stamp it, put all your registration details on it, sign it, and give it to the client to take to the pharmacy for their first dose. That's just so that they're ID'd and they can't send anybody else in to collect their dose or get it administered. And obviously prior to the time you've checked out for pharmacy vacancies and if they're willing to take that client on, and then issuing a script. Face to face.
Michelle, you got 3 minutes.
Yeah, you told me 5, Darren.
You haven't stopped talking.
Every second day. So that's what I would do, and phone contact every other day. I prefer to put people on Suboxone and starting doses around 4 milligrams and then 4 milligrams several hours after and titrating upwards. But you go with what you're seeing and what you're observing with the clients. Methadone commencing at 30 milligrams for naive and 40 milligrams if they're not naive, and titrating up by 5 milligrams every 2 weeks until stable. Next one. So within methadone, you're going a lot slower. You can ramp up the Suboxone a lot quicker. Buprenorphine, Suboxone, Subutex, partial agonist, effective in withdrawal from opioids as well. And the forms, the Subutex, the tablet form, that's used less around our area. I don't know about others. Suboxone, sublingual film, stops people passing things on. Norspan patches, usually in the older people in nursing homes and places like that, they like the Norspan patches. And now we've got the golden having the long-acting injectable buprenorphines, as in Sublocade and Buvidal, and the choice of weekly with Buvidal and monthly with both Sublocade and Buvidal. Buprenorphine effectiveness, treatment for any opioid, and obviously they can't use on top, or it just flicks it off. And combining all these opioid agonist therapies with counselling, that's where I've got the luxury of, I've got counsellors, I've got various other things, supportive networks, including peer supports, family networks and support groups. Methadone is your full agonist and is manufactured and belongs to a group of drugs known as the opioids. And the reason why I prefer Suboxone, clients know, and it's a well-known fact, they can use on top. And this is extremely, extremely dangerous. But do you know what? They still do it. And even with buprenorphine, going back to that one, clients, I always tell them that once we're on a stable dose, if you use any opioids on top, you're wasting your money. But you know what? 95% of my clients will still try it. And they'll come back and they go, I remember you telling me that if I used opioids on top, I wouldn't feel the effect and I'd be wasting my money. And they said, yeah, you are. So on to the long-acting injectables. So as I said before, we've oh, sorry, I've skipped one. Methadone. Generally, there are 2 types of methadone programs, maintenance or long-term. and it's all listed there. Withdrawal, I haven't really saw much of the short-term detox programs with methadone. Maybe other people have experienced it more in different parts of the country, but personally, I haven't really saw much of withdrawal short-term. Okay. And then we're on to the long-acting injectables of buprenorphine. So you've got the Sublocade or the Buvidal. I give the client the choice after education on the LAIBs. It's all about giving client choice. I stabilize them, I script them, and then I send them to the community pharmacy. So might be an option for you in your workplace. And I get an email from the pharmacy just saying that they've actually dispensed it, administered it, and then I schedule a catch up with the client 2 days before the next one, and then the process starts all again. It just saves you having scheduled drug fridges, safes in your organisation, and it normalizes it as well. And that's a thing that I've started doing, and I'm working with the Pharmacy Guild to get an education package out for pharmacists in the state of Victoria. But I think it's absolutely fantastic, and the clients go in just like they're going in to get their flu injection.
Do you want to wrap up now, Michelle?
Yep.
Thank you.
So that's just a stabilization of dosing and the signs and symptoms of what to look for so that you can say that they're inadequate dosing and they're starting to get into a bit of withdrawal. And it's basically the same list as what you would be expecting with withdrawals. And next one is just all the references and the resources that I sort of have pulled some of the data from, and trying to get the up to date stats. But there is a big gap there in a lag because of obviously COVID impact. So I know it's a lot of information, but you know, I'm more than happy if somebody just emails me and asks for some guidance. I've had GPs that have phoned me, and the same with the nurse practitioners. You just have to pick up the phone if you're unsure when you're starting off, because the worst thing I would think is leaving somebody there to absolutely panic about their prescribing.
Thanks, Michelle.
Okay.
Thank you. Thank you. I just want to thank Michelle very much for that very detailed review of opioids and opioid dependence and withdrawal. And I suppose I was keeping an eye out on some of the questions. We do need to be mindful that different things happen. You can, if you looked at with various withdrawal services in New South Wales, you would have differences happening in every one of them. And we know that in various jurisdictions and states and territories, there's also differences. So, and I think that's why, we can really add to one another. And look, we've got a question period now for 4 minutes. One thing I really wanted to highlight, and I know Michelle in Victoria have non-residential withdrawal. In New South Wales, if you're connected to, there's a lot of public detoxes, which are connected to hospitals, which means that you actually wouldn't put someone on a withdrawal with symptomatic relief. You would use buprenorphine or Suboxone, and probably do a 5-day slow titrating regime. But as you said, with permits, it's very different in each state and what you need to apply for within a hospital and within the community. So I think that's really interesting. there were a lot of questions that actually came out of that, which was fantastic. So I'd ask people if you really want to ask some questions. The one that really came up, Michelle, if you wouldn't mind answering, if you don't mind coming off mute. You mentioned about doing the ECGs, and there was a bit of confusion about on the Suboxone. You mentioned it. And I know various places will do ECGs for QTC prolongation to keep people on an opioid pharmacotherapy. But a lot of that people think, you know, that's normally connected to methadone. Can you just elaborate on that a little bit for us
Yeah,
for your
so
service?
yeah, it was brought up in the community of practice, which is part of St. Vincent's, our echo education on a Wednesday, and it's basically the elongation as well and the cardiac complications. And it came out after the coroner had investigated a few deaths for opioid agonist therapy, especially using Suboxone, and that they should be doing ECGs at least on an annual basis, and these people that are on these long-term therapies should be having like annual checkups. So it's just something to add to your
Yep.
physical health as well.
Thanks, Michelle. Does anybody have any questions they'd like to ask Michelle? I know there was a lot that went around there, but I think given the opportunity, we've got a couple of minutes. If someone would like to actually get off and ask Michelle a question.
Well, somebody's just asked about
Lee?
Hey Michelle, it's Lee Kelleher from St Kilda. How are you?
hi. Yeah, good.
Thank you. That was great. Yeah, I was just curious because I didn't know whether because of the, I'm sure that most states the same, but there's a big push around long-acting injectables, whether that has come into play in relation to the cardiac problems that are associated with it, because there's been more of an uptake with long-acting injectables, or is it just specific to buprenorphine per se?
I think they've just done it across the board as part of physical health screening. Just do it for everybody. Do it at the beginning of treatment and try and do it as part of your annual review.
Yeah, it makes sense.
Would anybody else have any questions they would like to ask before we move off into our 5-minute break? No, okay. I'll hold it there. Look, some great questions came out of that, and thanks for people to those that actually answered those. I will ask though, and in future, that people keep their cameras on. We've asked that before, and I'm going to ask that when you return to the peer education, peer support, you keep your camera on. Okay, thank you. If you want to just pop off now for 5 minutes, and for those that are not connected with the CCC program, thanks for joining us, and I hope you have a good evening, and I hope you catch us at the next educational section next month, which will be on hepatitis C virus provided by Jason Harrison. So see you all in 5 minutes, everybody.